Hello, my name is Sebag Olmesekan and I will be presenting the depression COPD case. Richard Taylor is a pleasant 54-year-old gentleman presenting to the clinic today for complaints of severe depression and a desire to take control of his life again. Patient states he has suffered from a terrible depression since his heart attack in 2015 and has exhibited a depressed mood consistently for the past 6 months. He has stated that he does not have any interest in his hobbies, which is building model trains in his basement, and has constant feelings of guilt, fatigue, and worthlessness. He feels less inclined in spending time with friends, and he has had trouble recently with his abilities to concentrate at work. RT states that this season is particularly difficult for his depression, with the colder weather, holidays, and spending his birthday alone contributing to his overall feelings of worthlessness. He does not exhibit suicidal ideations or any symptoms of bipolar disease, mania, or anxiety. He does not express any symptoms of insomnia. RT stated that he attempted treatment with citalopram, which was prescribed by cardiology 2 years ago. It worked well for improving symptoms, but he complained that it caused erectile dysfunction and diarrhea. Today he is actively seeking treatment for his depression and would like to pursue drug therapy again, but with something that does not have the same side effects. He states that if he can control his depression, he would be willing to attempt quitting smoking, and if he can just breathe a little better, he may even start an exercise regimen. He does not exhibit severe breathlessness at rest, but does complain of mild shortness of breath and trouble breathing while exercising. He would love to be able to exercise again and lose some of his excess weight. He does not exhibit any signs of bronchitis with his COPD. His past medical history is consistent of obesity, dyslipidemia, history of MI, COPD, and depression, family history of CVD and depression, social history. He is an active smoker of 1 pack per day, and he is married, which his wife has passed away, and he is an occasional alcohol drinker. His medication list include metoprolol succinate 50 milligrams a day, fluticasone 100 micrograms, 1 inhalation twice daily, albuterol multidose inhaler 2 puffs every 4 hours as needed for shortness of breath, atorvastatin 80 milligrams once daily, and aspirin 325 milligrams once daily. He is allergic to adhesives. His list of problems include, in order of high priority, depression and COPD, and then obesity and dyslipidemia. An assessment of his disease and his depression, according to the patient's HAM-D score of 16, he is suffering from moderate depression. Patient is also complaining of signs of terrible depression, including loss of interest in hobbies, constant feelings of guilt, fatigue, and worthlessness, and depression symptoms have affected his social life and performance at work. His COPD, this patient's spirometry results of FEV1 of 52% and FEV1 to FVC of 0.63 categorizes his COPD as Gold 2, which is moderate severity, and his number of exacerbations without hospitalization and his CAT score of 21 categorize him in Group B based on the Gold guidelines, which is low risk and more symptoms. Assessment of his depression. Patient's depression is not currently being pharmacologically treated, and a current plan of restarting citalopram 40 mg is not appropriate due to the side effect profile of the medication and the patient's prior experience. Patient may benefit from cognitive behavioral therapy along with proper medication therapy for depression. Goal of the therapy should be improvements in the symptoms of depression. In the plan for the recommendation for depression, according to the American Psychiatric Association guidelines, an antidepressant is recommended as an initial treatment choice for patients with mild to moderate major depressive disorder. The guidelines states that since the effectiveness of antidepressants are generally comparable between and within classes, the initial selection of an antidepressant will largely be based on the anticipated side effects, safety, tolerability of the drugs. The guideline also states that for most patients, an SSRI, SNRI, mirtazapine, or bupropion is an optimum choice. Since RT has experienced undesirable class-specific side effects with citalopram in the past, A medication other than an SSRI should be prescribed for the treatment of his depression. An appropriate agent with minimal side effects for him is bupropion SR. Bupropion SR should be initiated at 150 milligrams once daily in the morning for 3 days, then increased to 150 milligrams twice daily. Treatment with bupropion SR will also be efficacious as a smoking cessation modality. Patients should be counseled about having realistic expectations about the delayed onset of effect for depression treatment, the possibility of drowsiness at initiation of treatment, thoughts of suicide, and blood pressure changes. As for monitoring for efficacy, we should monitor for improvements in the symptoms of depression. And for safety, we should monitor for worsening of depression, suicidality, blood pressure at baseline and throughout treatment, and renal and hepatic functions. Recommendation 2 for COPD. According to the GOLD guidelines, disease severity should partly guide the pharmacologic and non-pharmacologic therapies. The first choice therapy for patients in Group B category is therapy with a long-acting bronchodilator, either a long-acting beta agonist or a long-acting muscarinic agonist, LABA or LAMA, based on symptom relief, and a short-acting bronchodilator available for symptom control on as-needed basis. And different meta-analyses have shown better efficacy of LAMAs when compared to LABAs. And patients should discontinue fluticasone and replace that with tiotropium, which according to the UPLIFT trial has shown to be safe for long-term use in patients with a history of cardiovascular disease. And tiotropium inhaler, which is Spiriva Respimat, should be dosed at 2 inhalations once a day. Patients should also continue the use of albuterol multidose inhaler as a rescue therapy and be educated on that there's no demonstrated advantage of the regular or scheduled use of albuterol, and it is only meant for as needed basis as a rescue therapy. The non-pharmacologic interventions for COPD include smoking cessation, pulmonary rehabilitation by a pulmonary therapist, vaccination against respiratory infections, which is influenza and pneumococcal, and our patient has had those immunizations in 2017, and also oxygen therapy. Patients should be educated on reducing risk factors such as cigarettes, proper use of inhalers, and goals of therapy. We also need to educate patients to follow a healthy diet and aim for reducing the BMI. Monitoring factors. For efficacy, we should monitor for improvement in pulmonary function tests and a reduced frequency of COPD exacerbation. And for safety, we should monitor for anticholinergic side effects of tiotropium. The third recommendation is about smoking cessation, and as previously mentioned, use of bupropion SR at a target dose of 150 mg twice daily will be an appropriate therapy option in assisting the patient in quitting smoking. This medication is also weight neutral, which will be desirable for RT who is overweight, and the duration of therapy with bupropion for assisting in smoking cessation is usually 7 to 12 weeks, which can be as long as 6 months, and the benefit risk of longer therapy duration should be evaluated individually. As for monitoring for efficacy in smoking cessation, we should monitor for abstinence from tobacco products, which is an indicator of the efficacy, and for safety, the same monitoring parameters as mentioned before. At the end, the patient should be scheduled for a follow-up with the PCP in about 4 to 6 weeks for the evaluation of the therapy efficacy overall. Thank you.